All right, I'm going to be making a video today on cardiology, particularly coronary disease. So to start off with, you understand that there are a couple different types of, categories of coronary disease, how you'd sort of classify this. First of all, you have someone that comes in with asymptomatic, let's put it this way, no symptoms. You somehow catch it with some other imaging or something like that. Another person who has something that's called a stable angina. And what is a stable angina? This basically means that it hurts when when they really exert themselves, like they run up the stairs, they do some exercising, it stops hurting when they rest. And then you have an unstable angina. And an unstable angina basically means that it hurts all the time. Then you have what you call an N-Stemi, which means not a ST elevation myocardial infarction. Let's call them N-Stemis. And then you have a STEMI, which means an ST elevation myocardial infarction. Okay, so there are your categories. This is the first area of categories. But then you've also got categories along the side, which I'm going to do like this. So you say there is pain, there is reliever. What is it relieved by? Then you've got your biomarkers, which are troponins or CKMB, that sort of thing. And then you've got your whether or not there's ST elevation or not, an EKG, and then you've got your percent occlusion. Okay, so let's go through this and talk about it. So first of all, looking at a non-symptomatic. Well, obviously there's no pain, and if there's no pain, then nothing relieves it. Whatever. There's going to be many biomarkers, no ST elevation, and there's going to be no occlusion. Well, actually, I take that back. There's going to be less than 50% occlusion. Okay, so if you look at it, usually it's going to have less than 50% occlusion. Okay, so what about I'm going to make that look a little bit prettier. Just going to put 50 here. Okay, so less than 50%. Okay, so what about a stable angina? So this is something that hurts when they walk, but it feels better when they rest. So pain with, I'll just say moving, pain when they, like exertion is what I mean by that, and reliever is rest. Okay, and then biomarkers, none. ST elevation, none. Usually this is going to be somewhere around 70% occluded. Okay, so next is a unstable angina. So in this case, there's even pain at rest. So I'm putting rest there. Nothing relieves it except for, maybe nitro. I guess you'd put nitroglycerin might relieve it. Biomarkers, none. ST elevation, none. And occlusion is usually looking at something like 90%. That's when this thing really hurts. Hurts all the time. Your heart is not getting enough blood. Okay, so now what about an N-STEMI? So what we mean by N-STEMI is you look on an EKG, you've performed an EKG, which is like one of the first things you do, and you see on this EKG that the person has either they have the ST segment is what they call it, so the segment from S to T, and you see that it's either elevated or it's not elevated. Maybe I should pull up what ST elevation looks like real quickly. So let's look here. Oh, there's the news. ST elevation. Let's see what a picture of that looks like. So here we go. Here's an example of what ST elevation looks like. So see here, P, Q, R, S, T. See the ST from S to T? This is elevated. Normally, it goes down right here, and it stays down like this. And then there's a little jump for T. Maybe we should find normal. So normally, it's going to look like this. You can kind of compare that. See this QRS and then ST. So here, PQRST, and then here's S and then T. See, before it was elevated right here, and now there's just an elevation on the T wave, but not there. Hopefully that makes some sense. So in that case, with an N-STEMI, so this is you perform the EKG, and there's not there's not an elevation there. So it hurts even at rest. Reliever, I don't know, same thing, whatever. I probably should have put nitro there. Nothing really relieves it. And biomarker. In this case, the biomarkers are going to be elevated in an end-STEMI. Now, a biomarker basically means when heart muscle dies, little pieces that were inside the cell come out. And one of the little pieces inside the cell is something called troponin. It's part of the myocardium structure. It comes out of the cell, and you can look in people's blood and you'll find, wow, they have troponin in their blood, which means their heart muscle is dying, and that's a bad thing. So they have troponin biomarker positive. That means that heart muscle is dying, and of course there's not ST elevation by definition, and occluded is usually somewhere like 90%. Now what about a STEMI? Now this is a really bad one. This is the one where the ST elevation is present, and this is painful even at rest. Nothing relieves it. Biomarkers are going to be increased, whether it's CKMB or whether it's troponin, and there is ST elevation, and the occlusion is 100% occluded. I mean, this is dying. Their heart muscle is dying. So that's kind of the first way to look at it. And you kind of classify these three here as something called demand ischemia. So based on how much demand you have on the heart is how ischemic it's going to be. But this one is a supply, which means it's not being supplied with blood. It's totally cut off, okay? So at what point do we tell someone to go home, or do we tell them, you need to stay in the hospital? Okay, where's that line? Well, the line of division of going home versus going to the hospital is going to be right here, okay? A stable angina can be managed at home. It's stable. An unstable angina, everything else, they need to go to the hospital, okay? So this is the hospital area, and this is the you can maybe go home area, okay? All right, so now let's look at a little algorithm here. I like making algorithms, and this maybe will be helpful for you. And let's look at what a person does. So a person comes into the hospital and they say, Doc, I got chest pain. And you say, okay, well, first of all, if you've got chest pain, one of the first things we're going to do for you is we're going to give you aspirin. They just do that. Boom. Give them I think it's a 325 milligrams, whatever it is, aspirin, and sometimes they'll even give them nitro here. Now, if they have nitroglycerin, if they have chest pain and you give them nitro and the chest pain goes away, then you're like, aha, this person has blood constriction to their heart, because when I gave them nitroglycerin, it expands the muscles and the blood vessels of the heart, makes them let go and relax, and that allows more blood to come through. And if their chest pain goes away when you do that, then you can say, well, they must have had a supply issue. They must have had the demand ischemia. So that's the first thing you do. So chest pain, give them those two things. Now what do you do? Well, first thing you're going to do is you're going to say, does this person have a STEMI, or do they have an end-STEMI? And EKG, ECG, whatever. So STEMI or end-STEMI. So that's the first thing you do, because if it's a STEMI, it is a super big emergency. This is a big deal. Their heart is dying right there. So you're gonna rule out the worst things first. Do an EKG. And if the EKG can show two things, it can either show that the person has a ST elevation, or it can show that they don't have an ST elevation. So let's say you do it, and sure enough, it shows ST elevation. Well, what are you going to do about that? Well, that is called an emergency, and you need to send them immediately to the cath lab. Okay, and the cath lab, it's really cool. They stick these, they look like fishing wire almost, into the person's body, and then they look on an x-ray and they find out what vessels are occluded. And if they look on there and they see, wow, you got like 3 or more vessels occluded, or they're like major vessels, then they're gonna do one thing, versus if they have less than 3. So if it's like 3 or more, they're gonna do something called coronary artery bypass graft. So coronary artery bypass graft, basically surgery. Okay, big deal. They're getting their heart cut open. They're going to be worked on here. They call that a CABG, C-A-B-G, coronary artery bypass graft. Now, if it's less than 3, or if they're not major ones, then they can use something called a stent. And that isn't as big a deal. A stent is they push this little thing in there that kind of opens up the blood vessel a little bit more to allow more blood to get through. And if they're put on a stent, they're going to be most likely put on clopidogrel. Okay, hopefully you can read what I'm saying there. Okay, so if they do a stent, probably going to be clopidogrel. If it is a metal stent, it'll have to be clopidogrel for like a year, versus the other ones might be like, months. But they're going to be probably put on clopidogrel if that's the case. Now, what if you did the EKG and you found that they didn't have an ST elevation, so they didn't have it, and so then what you're going to do is you say, well, what about troponins? Those are those biomarkers. Were the troponins elevated? And in other words, is their heart muscle dying? You say, okay, let's say that it was elevated. Troponins elevated. If it is elevated, then you say this person has heart muscle that's dying. They need to go to the cath lab. Now, is it a freaky emergency like this was? It's not as much as an emergency, but it's still not a good deal. So they got to go to the cath lab, and then they're going to look and they're going to do the same other thing here. So what if the troponins were not elevated? So not elevated troponins. Well, then you're going to do something called a stress test. Okay? Stress test. And they can stress you with either running on a treadmill, or they can give you medication. The medication that gives you like adenosine or dobutamine. Now, if they give you, the only reason why they would do medication is if they can't run for some reason. Like, let's say they've got a broken leg, or they've got an amputation, or they're so obese they can't walk, or I don't know, something like that. Some reason you do the stress test, but you either do the pharmacological stress test, or you do an actual physical treadmill stress test. Now, if that does elicit pain, then guess what? They got to go to the cath lab. They've got heart problems. And if not, then we're just going to have to monitor them or whatever. It's not something that you need to send to the cath lab for. So that's kind of the algorithm that you'd use there for determining what to do. And, if they don't do an ECG, there's also an echo you can do. Kind of gives you a good imaging, or you can do, nuclear as well, sort of viewing thing here. That's at this step here where the EKG was. So that kind of hopefully will clear up sort of what to do with that. Now, as far as what to do for these people, there is another kind of, acronym that you can use that's really helpful, and it's called MONA-BASH. MONA-BASH. As soon as they say MONA-BASH, C. And what this is morphine. You got to realize chest pain is extremely painful. I mean, the heart attacks are extremely painful. So if you do find out that they're having some sort of heart attack, coronary ischemic event, then you're going to say, all right, let's give this person some morphine. Pretty much everybody is going to get oxygen, because even if it doesn't show up that they have decreased oxygen, any amount of oxygen you can send to the heart is going to help it out. Okay, nitro. That can be a test, but a lot of times they'll give people nitro if they're having chest pain. That's something they may have already even done at home, and pretty typical, always done. And everybody that comes in is going to get aspirin. I mean, you come in, you say you got chest pain, and you're in that kind of age category. Here you go, have some aspirin. Just what you do. Now, the next three here are medications that you'd give people, most people anyways, especially if they've got any troponins or EKG. But this is a pretty typical thing. Somebody comes in and you think yes, they're having some sort of ischemic event, or their stress test was positive. You're going to give them a beta blocker. You're going to give them an ACE inhibitor that lowers blood pressure. Beta blocker slows the heart down. ACE inhibitor is going to decrease their blood pressure. You give them a statin, which is going to decrease the amount of fat running through the blood vessels, which is kind of what caused this in the first place. And then lastly, you've got heparin and clopidogrel. Remember, we gave clopidogrel to the people who got a stent done. So they went to the cath lab and they only had like 1 or 2 blood vessels occluded, and they get a stent. Those people are going to get clopidogrel. And heparin is kind of your call for other kinds of situations. So, but it's not a norm. You don't give everybody heparin that comes in. All right. Well, I hope that was helpful. The only other things that are involved in this whole process is in your process of them coming in, you need to make sure that you give a really good HPI. You need to make sure that you look at their risk factors while in that HPI. And you need to make sure that you've looked at any associated symptoms. And you need to make sure that you perform a physical exam. And let me talk about different aspects of this real quickly. So, under your HPI, you need to make sure that, when you're asking about this, you say, is there any substernal chest pain? Okay, that's a big deal. Is it worse with exertion? These are all questions as I misspelled that. Oh well. Is it relieved by nitroglycerin? And if with these three sorts of symptoms, any of those three ones, if it's 3 out of 3, they say, yeah, I was all 3 of those, then you'd say, wow, that is typical of chest pain. If it's 2 out of 3 and they still end up having a heart attack, you'd say, well, okay, that was atypical. Doesn't mean that they're not having one. And if it's 1 out of 3, then you'd say, this is not involved with your heart. Non-anginal, okay? That's kind of how you do that. So what about the risk factors? Now we're looking at the risk factors, and we're going to say, okay, what are some risk factors? Diabetes, smoking, hypertension, obesity, those kinds of things like that. Or even also, those are ones they control, but ones they can't control are their own family history. If there's a family history, it puts you at risk. Or their age. Age, if they are, less than 45 years old for a woman, or if they are age greater than 55 for 45 for a woman, or if they are greater than 55 for a man, then you'd say, uh-oh, you are at risk. Now, also the associated symptoms. Are there any associated symptoms? Well, are they short of breath? And are they experiencing any presyncope, which means kind of like dizziness in their head? Those are some of the things. And then lastly, on their physical, while you're looking at them, is the pain non-pleuritic? Means like not associated with their lungs. Is it non-positional, so it doesn't hurt more in some position or other, and also non-tender. When you feel their chest wall, they're not like, ouch, because maybe they have a broken rib. It's in chest pain at all, You got to find out what the source is when you're touching things around. So anyway, that kind of concludes everything, and I hope that video was helpful.